Hi, my name is Yvonne and I am a 2022 PharmD candidate. I will be presenting on levothyroxine, or commonly seen as Synthroid and Levoxyl. We will start off with some main patient counseling points. Levothyroxine is used to treat an underactive thyroid. It should be taken on an empty stomach 30 to 60 minutes before breakfast. It may take 4 to 8 weeks before seeing any symptom improvement. Be sure to separate iron or calcium-containing products by at least 4 hours. Some common side effects include appetite or weight changes, diarrhea, hair loss, nervousness, or trouble sleeping. Some more serious side effects include itching, hives, swelling of the face, hands, mouth, or throat, chest pain that may spread, confusion, unusual tiredness or weakness, dizziness, lightheadedness, fast pounding or uneven heartbeat, seizures or tremors, and in children, you want to watch out for a severe headache, blurred or doubled vision, or walking with a limp, knee, or hip pain. If you notice any of these side effects, be sure to contact your doctor right away. Levothyroxine is a synthetic form of thyroxine, or T4, which is an endogenous thyroid hormone. It can be used to treat primary, thyroidal, secondary, pituitary, tertiary, hypothalamic hypothyroidism, a rare life-threatening conditioning called myxedema coma, and it can be used as adjunct to surgery and radioiodine therapy for pituitary thyrotropin-stimulating hormone suppression. Mechanism of action. Levothyroxine, or T4, is converted to its active metabolite, L-triiodothyronine, also known as T3. T4 and T3 then diffuse into the cell nucleus and bind to thyroid receptor proteins attached to DNA. This hormone nuclear receptor complex activates gene transcription and synthesis of messenger RNA and cytoplasmic protein. The physiological actions of thyroid hormones are produced predominantly by T3, the majority of which, approximately 80%, is derived from T4 by deiodination in peripheral tissues. These physiological actions include normal metabolism, growth and development, promoting gluconeogenesis, increasing utilization and mobilization of glycogen stores, stimulating protein synthesis, and increasing basal metabolic rate. Dosage and formulations. Levothyroxine comes in oral tablets, capsules, and solutions, and as an intravenous formulation. The tablets are available in 3 brands, Euthyrox, Levoxyl, and Synthroid, and also as the generic. The capsules are available in brand as Tirosint and as the generic. They come in strengths ranging from 13 to 300 micrograms. The solution form is available in 2 brands, Liquidity and Tirosint SOL, in strengths ranging from 13 up to 200 micrograms per milliliter. The dosage strengths for these vary and are based on brand. As for the IV formulation, it has 3 different formulations, as a solution in 100 micrograms per 5 ml, a preservative-free solution in 100, 200, and 300 micrograms per 5 ml, and as a reconstituted preservative-free solution in strengths of 100, 200, and 500 micrograms. Dose recommendations. For hypothyroidism, the dose is individualized according to the clinical response and serum TSH, or thyroid-stimulating hormone, and free T4 concentrations. The average dose is about 1.6 micrograms per kilogram per day. For primary hypothyroidism, you want to adjust the initial dose by 12 to 25 micrograms per day every 3 to 6 weeks until their TSH level is stable for greater than or equal to 6 weeks. Patients that are less than or equal to 60 without evidence of coronary heart disease start with an initial dose of 1.6 micrograms per kilogram per day. Patients that are greater than 60 years of age without evidence of coronary heart disease Start with an initial dose of 25 to 50 micrograms once daily. For patients with coronary heart disease, you want to start with an initial dose of 12.5 to 50 micrograms once daily. For secondary or tertiary hypothyroidism, patients should undergo assessment of their pituitary adrenal function prior to initiation of therapy. If shown to have adrenal insufficiency, concomitant administration of a glucocorticoid is recommended to prevent an adrenal crisis. You want to also start with an initial dose of 1.6 micrograms per kilogram per day. For myxedema coma, an IV initial loading dose of 200 to 400 micrograms as a slow bolus, followed by a daily replacement dose of 50 to 100 micrograms until the patient improves clinically and can transition to oral therapy. For smaller or older patients and those with a history of or at risk for coronary disease or arrhythmia, consider doses on the lower end of the dosing range. Concomitant glucocorticoid therapy is required until the possibility of coexisting adrenal insufficiency is excluded. TSH suppression for well-differentiated thyroid cancer of the papillary and follicular, it is recommended an initial dose of 1.6 to 2 micrograms per kilogram per day immediately post-surgery and dose adjusted as needed in 6 weeks based on their TSH suppression goals. The dosage is highly individualized as the degree of TSH suppression is initially based on the risk of disease recurrence, using a staging system such as the American Thyroid Association ATA risk of recurrence stratification system. Long-term TSH suppression goals should account for response to therapy, risk of recurrent disease, age, and comorbid conditions. No dose adjustments are needed for renal or hepatic impairment, no matter the severity. Precautions. New or worsening cardiac abnormalities, such as increase in heart rate, angina, and arrhythmias, may develop with overtreatment. You want to be cautious in elderly as they are at greater risk for cardiovascular events. Surgical procedures in patients with pre-existing coronary artery disease increases the risk of cardiac arrhythmias. For chronic autoimmune thyroiditis with progression to mixed edema or acute adrenal crisis, it may occur in association with other autoimmune disorders, such as adrenal insufficiency, diabetes, and pernicious anemia. For concomitant adrenal insufficiency or concomitant pernicious anemia, you want to treat with replacement glucocorticoids prior to initiation of levothyroxine to avoid acute adrenal crisis. It may cause worsening glycemic control in diabetic patients. Decreased bone mineral density may occur, especially in postmenopausal women. For product interchangeability, switching between different levothyroxine products may result in variations in the administered dose and altered TSH values and is not generally recommended. If formulations are changed, close monitoring of TSH is recommended. Contraindications. Hypersensitivity to thyroid hormone or any component of the product or glycerol. Acute myocardial infarction. Non-toxic diffuse goiter or nodular thyroid disease with suppressed TSH. You have the risk of precipitating overt thyrotoxicosis, especially in elderly and those with cardiovascular disease. Subclinical or overt thyrotoxicosis, and uncorrected adrenal insufficiency, which may precipitate acute adrenal crisis. Monitoring parameters include heart rate, blood pressure, new or worsened cardiac symptoms, for example, chest pain, palpitations, edema, clinical signs of hypo and hyperthyroidism, and bone mineral density, especially in long-term use in postmenopausal women. Here are my references, and thank you for listening to my presentation.